My name is Ramsey Chambers. I head up product at KitCheck. And today, Huzefa Raja from Edward Hospital has been gracious enough to agree to share some of the work that they've been doing with KitCheck at their hospital, specifically in the OR. Huzefa is the supervisor over the OR pharmacy, and I think he has a lot of great, interesting information to share with everybody. So with that, I will turn it over to you, Huzefa.
Thanks, Ramsey. Good afternoon, everybody. Thanks for taking the time out. My name is Huzefa Raja. I am the OR Pharmacy Supervisor at Edward Hospital. I just want to go over a few things that we're doing with KitCheck, to help with our workflow processes and with the anesthesia trays in particular. So first, the history and the initial benefits of KitCheck. We went live with the technology back in November 2015. It's added a great layer of safety and accuracy. So that's been one of the best benefits of KitCheck so far. With so many lookalike, sound-alike drugs, and situations with drug shortages and having to purchase new NDCs and new manufacturers where certain vials start to look the same or you're getting new vials, it's nice to have that extra layer of safety and accuracy. The ease of use, it saved technician time refilling trays. It's also saved pharmacist time checking trays. Before, to get through our day, the techs would have to memorize what's in the trays, the par levels that are in the trays, and the pharmacists as well, to be able to check the trays properly. Now, if the situation arises, we're able to have a tech float through, or a pharmacist float through the OR and use KitCheck as a guide when refilling the trays. So that's been great. It's saved time, and it's given us a little bit more flexibility as well in terms of staffing. We also use the bin scanning and the inventory control. That's been great. It pretty much allows anybody to order based off the inventory list and to see what's below our suggested par levels. And the reports that we've been using have been helpful as well. The items consumed and removed report is a great way of keeping track of how much we're dispensing. The activity analytics helps us with workflow and staffing. And then the expiration analytics, we'll talk a little bit more about how we use that later. But we're a hospital in Naperville, Illinois. It's a suburb of Chicago. It's about a little over 350 beds. So that's kind of the setting that we're using KitCheck in. So for the OR and the anesthesia trays in particular, we currently have 43 anesthesia trays in circulation. Our model is the day tray model, where we load the drugs in a tray and then they get used throughout the day. They get turned over once, maybe twice a day. We have 116 items in each tray, and we do about 21 turnovers a day. And based on the data that we got back, that we could see in KitCheck, we use about, on average, 564 items that we refill in the trays every day. So at this point, we're way past the basics of operationally using KitCheck for day-to-day functions. So now with all the data available to us, it's about exploring and finding ways to utilize that data to improve our processes, lower costs, and improve care. So that's where we're at right now. That's kind of what we're looking to do with the data in KitCheck. So the objectives today with this project were to improve the layout in the anesthesia tray for convenience and accessibility, and optimize par levels based on historical usage data, to proactively manage the expiration dates to minimize waste, and to adhere to best practice guidelines and regulatory standards. So in terms of improving layout, goals would be to eliminate redundancies, make commonly used drugs more easily accessible, and that term is kind of just little things where you're moving faster moving drugs to the front of the tray so that the doctor doesn't always have to open the drawer all the way to grab what they need. It seems like a little minor thing, but in terms of the actual workflow and convenience level, it's something I think that they've mentioned to me and that they appreciate as well. So kind of keeping in mind the anesthesiologist workflow and how we can make it easier for them, it goes a long way. And then also to reduce the clutter, whether that's like the volume of drugs or the amount of tags that we have in the tray. So for improving layout, one of the goals for this was to eliminate redundancies. So that's an opportunity just to look at all the medications that you have in the trays, and are there any redundancies? Because when the trays got built, it was pretty much if you had asked all 50 or so docs that you have what they want in the trays, you probably get close to 50 different opinions. So it's good to look at everything that you have and see if there's any opportunities to consolidate. So for us, one example was the lidocaine 1% ampules. We carry both the 2 ml ampule and 5 ml ampules. Looking at the data that we get back, the 5 mLs get used 76% of the time. The price difference between the two for us was only about 9 to 10 cents. So it made sense to just get rid of one and then just use the 5 mLs exclusively. So that's one of the things that we wanted to do. And then also the increased use of pre-filled syringes with the KitCheck embedded tags that we got from PharMedium. There's the industry standards that are required by the Joint Commission and the CDC, saying that labeled compounds should include the drug name, strength, amount, date, and initials. So that has a few benefits for us. Number one, it reduces the amount of clutter of the tags that are sticking out because the KitCheck tag is actually embedded into the syringe. It saves us the cost of the tag and the labor of tagging the med. So in terms of which PharMedium syringes which pre-filled syringes we targeted, as we looked at the meds in the tray that typically require dilution. So that would be ephedrine, phenylephrine, and we looked at the concentrations that the docs, the anesthesiologists typically use, and we identified those as potential opportunities because number one, it saves steps for the doc, so they don't have to actually like break the amp, use a filter, needle, and make the dilution, and then the labeling is compliant since it has all the drug name, strength, amount, and date. They're easy to read. And it comes out to be a relatively cost-neutral scenario if you're looking at it from a unit per patient standpoint. So, for example, if you make a dilution of ephedrine where you're mixing the 15 milligrams of ephedrine into a 100 cc bag and only using 2 or 3 cc's of it, you're not going to be able to use that dilution for multiple patients. So that's kind of how we saw it in terms of that. So it's a great convenience aspect for the docs to have these pre-filled syringes, and it reduces clutter in the trays for pharmacy and reduces a little bit of the work involved for us actually labeling these syringes. So for the tray redesign, we wanted to match the layout of the tray with the workflow. So what we have right now is all the drugs in the tray, and it's a little bit of a random organization of where all those drugs are. The docs now, they're used to the layout, but we wanted to match the layout to mimic their workflow, which basically means we'll have the antibiotic, the pre-op antibiotics, in one place, then we'll go to the sedatives, and then the paralytics, and then your cardiovascular drugs, your reversible agents, and then your antiemetics. So everything will kind of be mirrored to how they use things. So it should be easier to find if we have new doctors start, or if doctors who don't have everything, all the locations of all drugs memorized, they'll kind of have a good idea of where to look in the tray to find what they need, and and have a good idea of their options of what's in the tray for an antiemetic, for example. The trays, and like I said earlier, the doctors all would have an opinion of what would need to be in the tray, but the trays have a finite amount of space. So the goal here is to optimize the amount of real estate you have and to not waste any space with drugs that don't move very quickly and drugs that don't move at all, and to also make those more commonly used drugs more accessible. So when we talk about optimizing the PAR levels, the advantage KitCheck gives us is an opportunity to use actual data to present and say, this is actually what's being used, and is there any way we can adjust up and down? So we use the advanced segment optimization report. And then we wanted to make it a way where we're not just saying, okay, can we change this and change this, but make it a more dynamic process where we're not just changing it once and then never looking at it. We establish maybe once a year or twice a year, we look at the data again and see, do we have the optimum PAR levels of all the drugs in our trade? So that's kind of putting in adjustment breakpoints, which are user defined. So whatever works for your specific place, do that, and then you can adjust it as you go. So for one example that we used is, we looked at all of them, but one example that I wanted to present was glycopyrrolate. So in the advanced segment optimization report, you can pull up, you go by Kitmaster, you pick your kit, and then you can kind of pick your parameters. But basically, the graph that you get is shows you your usage over time. So for us, we normally kept 10 vials of glycopyrrolate in our trays. So if you could see this highlighted bar right here, it tells us 96.07% of the time the dispatches consumed 7 or fewer of the items of this segment, which basically meant 96% of the time you didn't even need those extra 3 vials in there. So for us, what we did was we decided on a breakpoint of 95%. So if we can cover 95% of the dispatches with our PAR levels, then that would be kind of the target PAR level for that drug. So for this, it would be an opportunity to cut down from 10 vials to 7 vials of the glycopyrrolate. Another example here is oxytocin in our trays. We had 4, and if you could see this middle column here, it says 99% of the time the dispatches consumed 2 or fewer. So you can easily go down to 2, maybe even 1 in those trays. So that's the kind of thing that we were looking at to see, like, where can we reduce, but it's not only about reducing. The whole point is more of optimizing. So the reducing, what that gives you, it gives you a chance to reduce the amount of expired meds and the costs associated with meds expiring. And then the other advantage of reducing some of the PAR levels is it gives you space for other stuff that does move, that you can, by looking at the data, you can tell that moves faster. So for example, for us, we have propofol 20 mL in our trays, and we keep 3 vials in those trays. So for us to determine where can we actually increase, or where is there an opportunity to increase the power levels to better accommodate the anesthesiologist, we look at the max consumed, or this last column here, the percentage of consuming the max. So how many times does this tray come back with nothing? It started with 3, it came back with 0. How many times does that do that? And if that number was greater than 10%, then for us, that was an opportunity to think maybe we can increase the par level for that drug, so that we're covering more than 90% of their of our dispatches, so they have enough. Because what was happening once in a while is that we turn over the trays once a day, but throughout the day we would have to switch out a tray here and there, and then we realized that only a few things need to be refilled. So it was obvious at that point that they didn't have enough of 1 or 2 specific drugs, and that forced them to turn over the tray, which added extra work for the pharmacy and inconvenience for the anesthesiologist having to switch out the trays. So that's kind of the structure of how we did it. So looking at adjustment breakpoints for where you can lower the par levels, in terms of saying we want to cover 95% of dispatches and have enough for 95% of dispatches, and then any opportunity where you were consuming the max 10 or more percent of the time, maybe we can add more in there. And then we'll make those changes, and then in 6 months or a year, we'll look at it again and see if that's enough. Maybe we'll need to add a little bit more, or maybe we can subtract more. So that's the goal, I think, and that's the value that KitCheck gives you, that allows you to have real-time actual data that's kind of ongoing, so that you can look at it at any point and make it a more dynamic process, and not always have to kind of restart from the beginning and seeing what you need to do. And so that's what we've been doing. Now, the other thing is we're doing a proactive management of expiration dates. So meds that are expiring soon, we're moving them to a higher use area. One example would be, we have epinephrine 1 milligram per 10 ml syringes in our anesthesia trays as an emergency med. It doesn't get used that often, but we don't want to just let that expire out and then essentially go to waste. So we set our limits as 60 days for the epinephrine and some of the other drugs in that tray. And then, for example, we can move those to the ER crash cart trays, which the epinephrine gets used pretty often in those. So looking at drugs and not letting them expire and kind of reallocating them to a different place where they would be used and more useful, that's another way that we can use the data and the reports available through KitCheck to do that. And that's available using the expiration analytics report available. So I think anesthesia is unique in the sense that they prescribe, dispense, and administer their own drugs. So there's not a pharmacist in the middle of that process necessarily. What I would recommend for people working in the OR is to shadow an anesthesiologist for a few days, see how their workflow is, and kind of get a look at how they're using drugs, when they're using drugs in the procedure, whether it's at the beginning, at the end, in the middle. Do they need to, how they're making their dilutions, and if there's a way that pharmacy can make it easier for them and improve their overall workflow with the doctors, nurses, the anesthesia techs, and the pharmacy department. And if there's any questions, we could take questions now. I've shared my contact information. I'd love to share and bounce ideas back and forth about solutions and ways to utilize the technology to improve the way we work. So I think overall we've just scratched the surface of the potential of what the technology can do, and it's just more about thinking and reimagining how things are done now versus how they could be done. So if you haven't redesigned your trays or even thought about redesigning your trays or optimizing your trays, this could be a good opportunity now that you have more information about usage and cost and all these other metrics to really make something that benefits your institution, as well as making workflow easier for the doctors and for the pharmacy and pharmacists as well. So with that, we can open it up to any questions that anyone may have.
Great, thanks, Huzefa. A couple of questions here, but as a reminder to folks, there's a question panel. Feel free to load up questions there, or if you'd really like to speak out loud, you can raise your hand. We can open up a mic for you as well. So a couple questions here. First one is, what size labels do you use? We use the newer barcode ones only. So the question is, do you use the detailed tags, the larger tags, or do you use the basic tags, the smaller tags?
We use the larger tags, the detailed tags. So that's why one of the advantages of using the far medium syringes in those situations is to reduce the amount of clutter with the tags that those large ones create.
And is there a specific reason why you go with the detailed tags, or is it more just that that's what was available when you guys got started?
That's what we had when we got started. I think those scan faster. So, but that's what's been working for us.
Yeah, and just a clarification, we have made a lot of improvements on the performance of the smaller tags for folks that are interested in them. So performance is largely on par with both size tags. So another question here. This question is about Pyxis anesthesia inventory, and I don't believe you guys are using Pyxis anesthesia workstations, but you can clarify that for me.
Yeah, no, we don't use the A stations, but this would still be relevant to that as well, where you just have an optimal amount of what you load into those, because those trays have a finite amount of space in there as well. So figuring out optimal par levels for that too.
Yeah, and there was this specific question was about how are they resetting par levels in the Pyxis anesthesia station when swapping out trays. But Rob, we can follow up with you and connect you with another customer that's actually doing that for that part of it. Edward, I'm actually being told that your sister hospital, Elmhurst, actually uses KitCheck for the Pyxis tray, so maybe that's a place where we can connect somebody up.
Right.
Another question, do you have refrigerated items in the tray? And if so, do you have any strategies to help the adhesion to the cold vials while keeping the appropriate storage temp?
That's an excellent question, and I can definitely relate to that issue. What we do for that is we do have refrigerated products, specifically rocuronium and famotidine is what we have in there. What we do and what seems to have worked for us in terms of that is when we're tagging the meds, we kind of fold the label so we're able to stick the adhesive back on the back of the label rather than wrapping it around the vial, because we've noticed that wrapping it around the vial, it comes undone. But if you can stick the adhesive onto the back of the actual KitCheck tag, then it sticks a lot better. And that involves bending the tag a little bit, but they still seem to scan pretty accurately. So that's what's worked well for us.
And just a quick clarification for some folks, the larger detailed tags have this kind of fold over where there's a much larger adhesive area if you want to use it. So for folks that were using the basic tag, that does not have that larger adhesive area, so that option wouldn't be um, an option in those particular cases. A little bit of a pain, but from what I've heard, the kind of just taking a towel, drying something off just before applying a tag to the refrigerated items can help. And then there's also some of those refrigerated items are available as pre-compounded syringes that don't actually require refrigeration. So whether or not you're buying a pre-compounded, pre-tagged syringe or just a pre-compounded syringe that doesn't need to be refrigerated, those are also options. Couple more questions. In the case where you were expanding or increasing the count of the par level, how did you make the decision about how much to increase it by?
For that we just increased it by 1 or 2. That was more like anecdotally deciding, and based on how much space we had in the tray. So those two kind of factors: how much space we had available and how much we thought would work. So that's part of the whole dynamic process of it, is where you can actually trial stuff and see if that works or not. So you can go up by 1 if you want, look at it in 3 months and see, is that actually keeping you within your target of your breakpoints. If that's not, then see if you can adjust it up another 1, or you can go up by 2 if you have the space, and then if you realize that that's too much, then you can always go back. So I guess for me, making the process dynamic and not being stuck with making one decision and never being able to change it, not the way to go. To be able to kind of try something out, look at the data, go back and make adjustments, so you're always kind of in that sweet spot.
Great. Another question here. Do you have any sense or an estimate amount you've reduced costs by optimizing trays, whether it be through inventory or expiration, eliminating expirations?
Yeah, so the actual goal of this process in the beginning wasn't focused specifically on saving costs. It was more to just make it more efficient, so that we're turning over the trays less, that the doctors have what they need, and that we just didn't have meds expiring out. Now, kind of as a side benefit of it, I think we will see a lot of cost savings in terms of less meds expiring, and less wastage in general with some of the pre-filled syringes, where we're not diluting we're not necessarily using the whole vial all the time. So we're still kind of in the process of rolling this out. So it's a little bit too early to see what the exact cost benefits are. Yeah, but those would be kind of the 2 areas where I would expect to see a lot of the cost savings, in terms of reduced amount of waste and fewer expired medications.
Great. Any more questions, folks? Again, feel free to type them in, or if you'd really like to speak out loud, you can raise your hand in the app, and we can unmute you briefly while you ask your question. Question about patient charging. How are you guys approaching your charging for patients based on what gets used, or charge on admin? What is your charge approach?
Our charge approach is we have the anesthesiologist fill out a charge sheet for each patient, and then we manually charge that later in the day or sometimes the next day. But that's how we do it. We don't do the charge on admin. We have like a paper charge sheet for each patient.
Have you guys ever compared kind of what they're marking versus what goes missing to see if there's any delta between those two?
Yeah, so that's another thing. When you use the items consumed or removed report and comparing that against what's actually charging, then you can identify areas where there could be missing charges or wastage. It's not necessarily always they forgot to charge for it, but sometimes they maybe prepared a dilution and didn't use it. So, and that may lead to cost savings, where if they think they may need some phenylephrine for that patient or some ephedrine, which they have to dilute, they may dilute that ahead of time and then end up not using it for the patient, and then that kind of goes to waste. But if you have these prefilled syringes at the dilution concentration that they want, then they don't have to worry about doing the dilution themselves. They'll have it ready on hand to use immediately. So yeah, we do look at that, and we communicate that to the anesthesia staff as well. So they're aware of it. They're aware of the drugs that where the biggest delta is for a lot of the fast-moving drugs, and like the essentially the low-hanging fruit in terms of the more expensive drugs that are in the trays as well. So they're conscious of those as well.
Just a quick plug to you, Huzefa, or anybody who's interested. We are willing to basically do some data analysis. If you're willing to give us your charge data, however that comes, and we'll actually do the analysis based on kind of what got charged in a particular window versus what went missing, so you can start to look at kind of what that delta is and whether or not there's anything to address. So if anybody is interested in that, just reach out to your KitCheck rep, and we're happy to engage in that type of project. It's an area that we're exploring, so it's not something we charge for. Just interested in learning from it. More questions here. How long do you allocate to swapping out trays in the OR? There's a comment with that, which is they do a full swap out of 3 trays per Pyxis machine, and 4 machine takes 45 minutes. Russell, clarification on that. Are you saying that you're doing KitCheck tray liner swaps and it's taking you 45 minutes, or servicing those machines in general takes 45 minutes? But, well, I'm hoping to get an answer to that. Just the question to you, Huzefa, of how long does it take for your team to basically swap out the OR trays when you do that?
Yeah, I would say between, I would guess roughly to take about 2 to 3 hours a day to do the full swap out of everything. In terms of the anesthesia tech, the techs are the ones that go and get the trays from the anesthesia carts, and then between us filling them and then refilling them back, that would be about 2 to 3 hours. But in the meantime, what happens is, there'll be random trays from random areas coming through that we have to swap out as well. So yeah, one of the goals is to reduce the amount of times we have to swap out the trays that are not in the scheduled period of the day where we want to do that, just in case they run out of something that they went through. That will inevitably happen no matter what, if they have a run on a certain drug, but the goal is to kind of identify where maybe we can accommodate them better so that they don't have to switch out trays before when we normally do.
More questions here. What kind of expiration dates are you receiving from Pharmedium? I'm assuming that's like how long out are they?
Yeah.
And how do you deal with the recalls or shortages where the pre-diluted product is not available or has been recalled?
Yeah, that's an excellent question. The expiration dates we're getting are generally about 90 days on the dilution, so that's pretty good. In the situation, if there was a shortage, and this is another great thing about KitCheck in general, it gives you a lot of flexibility. So if you weren't able to get your ephedrine dilution, you can always update the kit master, do an alternate fill option, and put in the vial for the time being until you're able to get your allocated amounts. So that flexibility is great if you had to like flip back and forth. Even now, as it is, we plan on having the pre-filled syringes, but we also will put one ampule in there as well in case they wanted to make a infusion or wanted to make a dilution at a different concentration. So we give them that option as well. But that's a great question.
Another question here, do you outsource all of the tagging to Pharmedium, or do you still tag some items in-house? And if so, what percentage is of kind of the items in a kit are pre-tagged versus you guys are tagging?
We tag a lot of our own stuff. I would estimate it to be we tag about 40% of our stuff and then outsource maybe 60%. So right in that neighborhood. The refrigerated products we'll tag ourselves, and then a lot of the other things too we'll tag, especially the slower moving drugs, just to make it easier.
Great. Any last questions? Well, those are some great questions. Huzefa, great presentation. Again, he's shared his contact information. If you guys are interested in kind of swapping ideas or problems, I think that what these guys have been doing have been very advanced in terms of their use of KitCheck and the data to try to really eke out every opportunity to optimize workflows or inventory. But thank you so much for taking the time to present, and for all the attendees, thank you for taking the time to listen, and have a great afternoon. Oh, wait a second. I take it back. There's a ton more questions here. Feel free to hop off, but in the event that people have a couple of minutes here. Oh, wait, no, I take it back. It was a reference to SafeCore, that you're using SafeCore for some of your tagging.
Right.
Yeah, so that's another option. So Pharmedium, pre-tag, SafeCore will tag standard items and then tagging in-house. All right, so that is it. Thank you, everybody, and have a great day.